Anatomy of the middle cerebral artery. The middle cerebral artery or MCA is the largest terminal branch of the internal carotid artery, and it is the most frequently involved artery in acute ischemic stroke. So it is the largest terminal branch of the internal carotid artery, and it supplies 70 to 80% of the lateral surface of the cerebral hemisphere. So this middle cerebral artery supplies 70 to 80% of the lateral surface of the cerebral hemisphere. So the MCA originates from the terminal bifurcation of the internal carotid artery within the sylvian or lateral fissure. Okay, so the MCA originates from the terminal bifurcation of the internal carotid artery within the sylvian or lateral fissure. So from its origin, it is divided into 4 anatomical segments designated M1 through M4. So the first segment, M1, this is also known as the sphenoidal segment. M1 is also known as the sphenoidal segment. So it extends from the internal carotid bifurcation. It extends from the internal carotid bifurcation to the Lyman insulae. Okay, so this is the most clinically important segment because it gives rise to the lenticulostriate arteries. So why this M1 segment is important? Because it gives rise to the lenticulostriate arteries. So these are small perforating end arteries that enter the brain through the anterior perforated substance. So these are the small perforating end arteries that enter the brain through the anterior perforated substance. So they supply the putamen, globus pallidus, head of the caudate nucleus, and the genu and posterior limb of the internal capsule. So what does they supply? The putamen, globus pallidus, head of the caudate nucleus, and the genu and posterior limb of the internal capsule. Since these vessels have virtually no collateral circulation, they are highly susceptible to hypertensive lipohyalinosis resulting in lacunar infarctions. Okay, so these vessels, they have virtually no collateral circulation, so that is why they are highly susceptible to hypertensive lipohyalinosis resulting in lacunar infarctions. So beyond the Lyman insulae, so the green color, the vessel enters the insular cortex as the M2 or insular segment. So within the sylvia fissure, it divides into superior and inferior divisions. So in the inferior, the insular segment in the within the sylvian fissure, it divides into superior and inferior divisions. So the superior division predominantly supplies the frontal lobe, including the primary motor cortex for the face and upper limb, the premotor cortex, the frontal eye field, and the Broca's area in the dominant hemisphere. So what does the superior division supply? It supplies the frontal lobe, including the primary motor cortex for the face and upper limb, the premotor cortex, the frontal eye field, and Broca's area in the dominant hemisphere. The inferior division supplies the lateral temporal cortex, inferior parietal lobule, auditory cortex, angular gyrus, and vernix area in the dominant hemisphere. So what does the inferior division supply? The inferior division supplies the lateral temporal cortex, inferior parietal lobule, auditory cortex, angular gyrus, and vernix area in the dominant hemisphere. So the M3 segment, so this is also known as the opercular segment. It courses over the frontal, parietal, and temporal opercula while remaining within the sylvian fissure. So it subsequently emerges onto the cortical surface as the M4 or cortical segment. So M3 segment is also known as the opercular segment, courses over the frontal, parietal, and temporal opercula. The M4 segment gives rise to numerous named cortical branches. So what are these numerous named cortical branches from the M4 segment? So these include the orbitofrontal artery, prefrontal, precentral, central or Rolandic, anterior parietal, posterior parietal, angular, temporooccipital and posterior temporal. So what are the branches of these M4 segments? So these are the orbitofrontal, prefrontal, central, central or Rolandic, angular, temporooccipital and posterior temporal artery. So collectively these branches supply most of the lateral, frontal, parietal and temporal lobes as well as the insular cortex. So from a functional perspective, the MCA territory includes the primary motor and sensory cortices responsible for movements and sensation of the face and upper limb. It also supplies the frontal eye fields, Broca's and Wernicke's language areas in the dominant hemisphere, the auditory cortex and extensive association cortices involved in higher cognitive functions. So from a functional perspective, the MCA territory includes the primary motor and sensory cortices responsible for movements and sensations of the face and upper limb, also supplies the frontal eye fields, Broca's and Wernicke's language area in the dominant hemisphere, the auditory cortex and extensive association cortices involved in higher cognitive functions. The vascular territory displayed on the slide highlights that the medial frontal and parietal cortex are supplied by the anterior cerebral artery, while the occipital lobe and inferior temporal cortex are supplied by the posterior cerebral artery. Medial frontal and parietal cortex are supplied by anterior cerebral artery, while the occipital lobe and inferior temporal cortex are supplied by the posterior cerebral artery. So this distinction is extremely useful when localizing stroke syndromes. Clinically, occlusion of the superior division of the middle cerebral artery typically produces contralateral weakness affecting the face and upper limb, gaze deviation towards the side of the lesion, and Broca's aphasia if the dominant hemisphere is involved. So, superior division of the middle cerebral artery occlusion produces contralateral weakness affecting the face and upper limb, gaze deviation towards the side of the lesion, and Broca's aphasia if the dominant hemisphere is involved. So if inferior division occlusion, it usually presents with inferior division occlusion presents with Wernicke's aphasia in the dominant hemisphere, contralateral superior quadrant anopia due to involvement of Meyer's loop, and hemispatial neglect when the non-dominant hemisphere is affected. So inferior division occlusion, Wernicke's aphasia in the dominant hemisphere, contralateral superior quadrant anopia due to involvement of the Meyer's loop, and hemispatial neglect when the non-dominant hemisphere is affected. A complete proximal M1 occlusion results in complete proximal M1 occlusion. So a complete proximal M1 occlusion, so this results in one of the classic large vessel stroke syndrome. So what is this classic large vessel stroke syndrome? Patients develop dense contralateral hemiplegia, hemisensory loss, homonymous hemianopia and cortical deficits such as aphasia or neglect depending on the hemisphere involved. A complete proximal M1 occlusion results in one of the classic large vessel stroke syndrome. So patients develop dense contralateral hemiplegia, hemisensory loss, homonymous hemianopia and cortical deficits such as aphasia or neglect depending on the hemisphere involved. So these patients are potential candidates for mechanical thrombectomy if they present within the appropriate therapeutic window. So one of the most important anatomical concepts is the lenticulostriate arteries. So because they are true end arteries, even small vessel occlusion can produce strategically located infarcts involving the internal capsule, leading to pure motor stroke. In contrast, proximal M1 occlusions produce extensive cortical and subcortical infarction with severe neurological deficits. Lenticulostriate arteries or true end arteries, small vessel occlusion, they produce strategically located infarcts involving the internal capsule, leading to pure motor stroke. Supposing if it is a proximal M1 occlusion, it produces extensive cortical and subcortical infarction with severe neurological deficits. So to summarize, the middle cerebral artery is the largest cerebral artery and the most commonly occluded intracranial vessel in ischemic stroke. So understanding its M1 through M4 segments, cortical branches, deep perforating arteries and vascular territories forms the foundation for accurate neurological localization, interpretation of CT angiography and selection of patients for reperfusion therapies. So here again summarizing the MCA in the Sylvian fissure. So here M1 it's a sphenoidal segment, M2 is insular segment and M3 is opercular segment, M4 on the cortical surface. So M4 lateral cerebral cortex, M3 over opercular branches, frontal, parietal, temporal, opercular. M2 within the insular Sylvian fissure divides into superior and inferior divisions, insula and opercular. M1 from internal carotid artery bifurcation to Lyman insula, it gives lenticulostriate arteries to basal ganglia and internal capsule. So this is the territory of the middle cerebral artery, lateral surface of the frontal lobe, lateral surface of the parietal lobe, superior and middle temporal gyri, insular cortex, includes motor and sensory cortex for face and upper limb, motor cortex and sensory cortex, Broca's area, dominant hemisphere, Wernicke's area, dominant hemisphere, and also the auditory cortex and frontal eye field. So what are the teaching pearls? MCA is the most commonly occluded artery. Lenticulostriate arteries or end arteries with no significant collateral circulation and are vulnerable to hypertension. MCA supplies face and upper limb predominantly. Lower limb is supplied mainly by the anterior cerebral artery. M1 occlusion, proximal large vessel occlusion, thrombectomy is the target. M2 occlusion, it is the distal large vessel occlusion. So what are the segments of middle cerebral artery? The segments are sphenoidal segment, insular segment, opercular segment and cortical segment. So this is the lenticulostriate arteries, branches of M1. Here you can see the caudate nucleus head, anterior limb of internal capsule, putamen, globus pallidus, genu, posterior limb, lenticulostriate arteries. So this supplies the M1, putamen, globus pallidus, caudate nucleus, internal capsule, anterior limb, genu and posterior limb. So if there is a superior division infarct, contralateral arm and face and arm weakness along with Broca's aphasia, gauge preference towards lesion, inferior division, Wernicke's aphasia dominant, contralateral superior quadrantanopia, hemispatial neglect non-dominant, complete contralateral hemiplegia, hemisensory loss, homonymous hemianopia. Homonymous, sometimes we'll be looking for homonymous hemianopia. This is seen with complete MCA occlusion. Along with that, there will be a hemisensory loss, aphasia dominant and neglect in the non-dominant region.